Ruchika is not still there.
She, I had called her. She probably was finding some problem. I'll check again.
Okay, she's come. Hello, Dr. Ruchika. Good evening.
Unmute.
Hi, good evening, Dr. Ruchika.
Can you just check your slides once?
Yeah, that's what even I wanted to. So I'll have to share the screen.
Yeah, I have allowed you to do that.
Yeah, just a minute. Is it visible, sir?
Yes.
Yes.
Yeah. I think in a minute or two we should start, I think.
Yeah.
You give me the signal and I'll start.
Okay. No, I mean, initially Dr. Goel will do some introductory bit and then you can start. Dr. Navneet hai kya?
So I have enabled everybody to join now.
Yeah, but can you see Dr. Navneet? Hey, ma'am. Yeah. Let's start, sir, then.
Good evening, Dr. Goyal. Good evening, Vishali.
Hi, ma'am. Good evening.
Hi, all good? Set to go?
Yeah, sure. Sir, let's start.
Yeah, just I think 1 or 2 minutes and.
Okay. The YouTube link and the recording, has it been turned on?
Yeah, it's live on YouTube and recording is going on.
कर जा रही हो?
Shall I?
Yes, yes, please.
Okay. Very good evening to all the faculty and all the delegates. I am Dr. Arun Goyal here, along with my colleague Dr. Vaishali Zamre. On behalf of Indian Anti-Cancer Trust as well as Max Institute of Cancer Care, I would like to welcome all of you to this webinar as part of our ongoing series of focus studies in breast cancer. We have been very enthused by the response we have had till now. And so as long as we keep on getting some interesting topics and a positive response from you people, we would like to continue. We had missed on the previous event because there were two conferences going on there. One was the annual conference of Oncology Forum and one was a Women's Breast Cancer Congress. So we had skipped one event. So the topic today, we jump from our routine of various issues in the breast cancer management to fibroepithelial lesions of the breast or Cystosarcoma Phyllodes. The disease is an enigma in itself, and I think this will be brought out by our speakers as well as in the panel discussion. There are problems in making a correct pathological diagnosis and in sort of planning the treatment which is suited to an individual patient. There are always surprises in clinical behavior also. So basically with that, we have planned this event in the form of two talks followed by a panel discussion. The first talk is a pathology talk, and we have an excellent speaker here, Dr. Ruchika Goyal. She is a senior consultant in the Department of Pathology at Medanta in Delhi NCR region, and she has a very special interest in breast pathology. We have previously had her in one of the events as a panelist, but this time we are going to hear her talk about the Phyllodes tumor and other spindle cell lesions of the breast, which can be sort of considered in the pathological diagnosis. So without wasting any further time, I would welcome Dr. Ruchika to start her presentation. Dr. Ruchika.
Thank you, sir, for your kind words. Thank you, Dr. Vishali, for having me here. So we'll just speak briefly into spindle cell lesions, and the focus today would be on the fibroepithelial neoplasms of the breast. Now, these spindle cell lesions are very notorious, and at times they are not what they actually look like. Now, spindle cell lesions can arise from three different types of cells. They can either arise from the epithelial cells, the myoepithelial cells, or the mesenchymal cells. When they arise from the epithelial and mesenchymal cells, they're known as fibroepithelial neoplasms. So they are basically proliferation of both epithelial and a mesenchymal component. Now, these are basically categorized into three types: fibroadenomas, the phyllodes tumor, and periductal stromal tumor, which is a recent entity, but which is generally, as its behavior and morphology is that of a phyllodes, it's considered a variant of phyllodes tumor. Now, we are all aware of the classical fibroadenoma. The classical fibroadenomas have two types of patterns: the intracanalicular and the pericanalicular pattern. Now, the intracanalicular pattern is basically, they have these compressed, so can you just hold on a minute? Hello?
Sure.
So just a minute, I think it's, just give me 1 second. I'm so sorry. I'm so sorry.
No worries. Go ahead.
So the fibroadenomas on histology have two types: the intracanalicular and the pericanalicular. Now, these intracanalicular pattern is what? Basically, where you have the infiltration of stroma between the ducts So your ducts become slit and compressed like. It is this pattern only which gets exaggerated, which one sees in a benign Phyllodes tumor. And then you have a pericanalicular pattern where you have these ducts with a concentric proliferation of stroma around them. So this is what you see in your conventional fibroadenomas. Just briefly into what are the other types of fibroadenomas we can encounter. We have the myxoid type, the complex type, the juvenile type, and the cellular fibroadenoma. What is the myxoid fibroadenoma? Now, these are fibroadenomas where the stroma is entirely myxoid. You'll see this loose bluish background. Now, our fibroadenomas normally also can have a myxoid stroma. So all classical fibroadenomas are not myxoid, but there are some fibroadenomas which are associated with the Parnes complex. So such patients might have atrial myxomas or cutaneous myxomas. So rarely these fibroadenomas might be associated with these lesions. The diagnostic pitfall in these tumors is in case of a core biopsy, if you have a hypercellular lesion, they can mimic your mucinous carcinomas. Otherwise, there is no increased risk of any malignancy. Complex fibroadenomas. We've all heard this entity. So what is this? Basically, these are normal fibroadenomas, but if they have one or more of the following histological features, like sclerosing adenosis, microcalcifications, cysts more than 3 millimeter, or papillary apocrine metaplasia, then they are labeled as complex fibroadenomas. And their relative risk of malignancy is slightly higher than that of conventional fibroadenomas. And that is not because of the fibroadenoma per se, but because of the proliferative changes which is occurring within the lesion. Juvenile fibroadenomas. So these lesions, which are generally seen in young female or adolescents, they can have a rapid increase in growth. The breast can become very enlarged, tensed, distorted. And though they generally occur in younger age group, there is a second peak which one sees is in the 4th decade. And when you see it in that category, then clinically and radiologically, they can mimic your benign phyllodes or your phyllodes tumor. The histology here is basically you have a pericanalicular growth pattern, and the stroma, though might show increase in cellularity and increase in mitosis, the atypia is generally minimal. And you have what is called here is the classical gynecomastoid type of florid hyperplasia. And coming on to last of the fibroadenomas, which can be very challenging for a pathologist, is your cellular fibroadenomas. Now, why are they called cellular? They are called cellular because they have increase in stromal cellularity. Unfortunately, this is a very subjective term because there are no definite quantitative criteria as to when to call it cellular. So there might be inter-observer variations. Secondly, when you have a core biopsy, then you will see this area, and then these would be labeled as just a fibroepithelial neoplasm with increased stromal cellularity, because you could have a benign phyllodes on the other end, or it might just be a cellular fibroadenoma. In 2012, the WHO had a school of thought which said that these lesions on core biopsy should ideally be conservatively reported and as fibroadenomas, so that their treatment should be a conservative approach. But the NCCN guidelines stated that since they can also be upgraded to phyllodes tumor, and phyllodes may have a different recurrence rate or a metastatic rate, one cannot just leave it on conservation. So this is the core biopsy which one can see in case of a fibroepithelial neoplasm with increased stromal cellularity. This is a classical fibroadenoma for comparison, but here you've seen increased stroma. There might be some kind of epithelial stromal condensation around the epithelium, increased mitosis, atypia, fragmentation of adipose tissue within stroma. So when such features are there, one can label it as a phyllodes, but at times this is not so clear cut. And so we are left with a diagnosis of fibroepithelial neoplasm with increased stromal cellularity. This was an article in the American Journal of Surgery which said that there is generally an upgrade of such lesions to phyllodes, and the rate of upgrade could anywhere be between 18 to 42%, and in their study it was 37.5. So such lesions cannot be left for conservative approach. This is our data for the last 5 years. In about 4,300 core biopsy samples, there were 20 biopsies which were labeled as fibroepithelial lesions with increased stromal cellularity. Out of this, 19 underwent excision, whereas one case was lost to follow-up. And in these patients, we saw that the upgrade, if I combine the borderline and malignant phyllodes, the upgrade was almost 42%. So though the data is very small here, but still there is an upgrade of these lesions. So I leave it to the surgeons as to what should be the protocol for such lesions. So now that we've come discussing on phyllodes tumor, this term was first coined by Johannes Müller, and the word phyllo is a Greek word for leaf, and odes means form. So it means a leaf-like form. The incidence of these tumors is generally less, about 0.5 to 1%, but it has a higher incidence in Asians, predominantly in the 4th to 5th decade. And this is the histology which one can see. You can see a circumscribed border, or it might be focally infiltrated. And you have areas like a fibroadenoma. And then you have these areas which have this leaf-like pattern. So these are generally characteristic of your benign phyllodes tumor, along with increased stromal cellularity. This stromal cellularity increase, there will be stromal atypia, mitosis. So you can have abnormal mitosis, stromal overgrowth. And though we have definite criteria on how to grade these tumors into benign, borderline, and malignant, at times you have overlapping features, and one still cannot differentiate between a borderline and a malignant phyllodes. So the dictum says that you've taken all those parameters along with grade the tumor in the worst area, provided that worst area is comprising at least 10% or more of your entire tumor. So just a brief recap into what are these criteria to divide them into benign, borderline, and malignant. You have the tumor border, stromal cellularity, stromal atypia, mitotic activity, which is one of the most important criteria, presence of malignant heterologous elements. Now, earlier, tumors like liposarcoma, angiosarcoma, rhabdomyosarcoma, any kind of malignant heterologous element is put into a category of malignant phyllodes tumor, irrespective of it has other features like overgrowth or atypia. But now the WHO has made an exception to liposarcoma, and liposarcoma is no longer put in the category of malignant phyllodes, because they're saying that the extramammary liposarcomas, which have the MDM2 and the CDK14 amplifications, is not seen in the breast tumors. And therefore, these tumors have low recurrence or low chances of metastasis. So it has been removed from the malignant category. When I was at Singapore General Hospital, this was the risk assessment tool that was used there. This was developed by Professor Tan and a team. And this basically gives a recurrence score as to how soon would the patient recur with the phyllodes tumor. And it takes 4 main categories into account. It talks about the stromal atypia, the mitotic activity, stromal overgrowth, and whether surgical margin is positive or not. They call it the Amos criteria. And based on that, they give a recurrence score. I will not be talking much about, I won't be talking about the surgical margin as we'll be having that in the next talk. So here, now that we are on phyllodes, you can also appreciate this leaf-like pattern. Yes, this is a phyllodes, maybe a borderline or a malignant. There is increased stromal cellularity. What gets tricky for a pathologist here is if a biopsy is done from this area. What would I see? Biopsy from this area would show me only sheets of spindle cells with nuclear pleomorphism and mitosis. So you have mitosis, increased nuclear pleomorphism. So on a core biopsy, how do we report it? Is it a spindle cell carcinoma or are we dealing with a malignant phyllodes? So when in doubt, when it comes to these high-grade spindle cell lesions, the dictum is always think of a spindle cell metaplastic carcinoma first unless proved otherwise. Now, these metaplastic carcinomas are known to have circumscribed borders, pushing margins, so they can clinically and radiologically mimic your phyllodes tumor. And especially if you see areas like this where you're just seeing sheets of spindle cells. Here comes the role of thorough grossing, thorough sampling, so that one can try and look for these areas which show epithelial differentiation. And if this is not there, we have a panel of IHC markers, a panel of cytokeratins along with P63, which can help us prove that it is a carcinoma. However, one should be wary, especially in core biopsies or limited tissue samples. Less than 5% of tumors can show cytokeratin positivity even in case of malignant phyllodes. So IHCs should be interpreted with caution in conjunction with morphology. So when morphology doesn't help, an IHC at times can be tricky. The next step is genomics. So in the last 5 years, there have been a lot of genetic studies going on these fibroepithelial lesions. And what has been seen is that there are two types of mutations which are commonly found in fibroadenoma and benign phyllodes tumor. Therefore, also in a way saying that maybe benign phyllodes have actually arisen from fibroadenomas. And these are the MED12, the MED12 and the RARA mutations. The MED12 mutations are known, tumors which have these MED12 mutations are known to have lower recurrence rate. And they're commonly seen in your fibroadenoma and phyllodes. But there's another mutation which is now gaining a lot of importance, are the third promoter mutations. Now, these are generally seen in case of phyllodes tumors and very rarely in fibroadenomas. So once this mutation is available clinically, one can use this to differentiate your fibroepithelial neoplasms. Also, your fibroadenoma and benign phyllodes tumor still share a lot of common mutations. But as the tumor moves towards the borderline and malignant spectrum, then the role of the cancer suppressor genes comes into play. And then you have mutations in genes like the EGFR, the RB1, the PIK3CA, and so on and so forth, which is not seen in your benign phyllodes tumor. So the clinical relevance of these, when they would actually be there in application, is we would be able to classify different fibroepithelial lesions. We'll be able to differentiate benign and borderline phyllodes, definitely. Differentiate a malignant phyllodes from a metaplastic carcinoma. And also there could be some therapeutic targets against specific mutations. However, till we don't have these available clinically, we again have to fall back on morphology. So coming back to core biopsies, again, you have two types of lesions here you can identify. So this is a low-grade spindle cell lesion, and this is a high-grade spindle cell lesion. So basically, spindle cell lesions, the low-grade ones and the high-grade ones have a host of differentials. And spindle cell lesions is a lecture totally in itself. So I will skip that part. However, one should remember that all these lesions have certain salient features. So the morphological characteristics along with IHCs can help in differentiating your low-grade spindle cell lesions from high-grade spindle cell lesions. Also, if one wants to refer, this is a very good article by Professor Tan in the Seminars in Diagnostic Pathology, where she's explained the approach to spindle cell lesions using morphology and IHC. But I won't go into details today. So just to summarize, fibroepithelial lesions are a challenge in core biopsy because of overlap in morphology and IHC, and especially in limited sample where the entire architecture cannot be studied. Also, we should be aware of different types of fibroadenomas. However, these don't have much clinical impact. Spindle cell neoplasms have a range of differentials, and one should have a step-by-step approach to differentiate your low-grade from high-grade lesions using morphology and IHC criteria. And yes, when we see malignant heterologous elements in a phyllodes tumor, it is always categorized as a malignant phyllodes, except liposarcoma is the exception here. And one should be very cautious when dealing with a core biopsy. And even if after doing all morphology, IHC, you're still in doubt, even though the surgeon may not appreciate it, but defer it to excision for definite categorization. That's only when in doubt occasionally. So with that, I'll conclude. Thank you.
Thank you, Dr. Ruchika. That was, I would say, a very nice presentation. Really covered the complexity of pathological issues when it comes to fibroepithelial lesions. And could you unshare your screen?
Yeah.
I think now we are going to have another very illuminating talk. And to deliver that, we have none other than Dr. Neeta Nair, who's a professor of surgical oncology in breast oncology services at Tata Memorial Hospital. And I wonder if some of you might have already noticed there's a publication which is in the preprint phase in Journal Clinical Breast Cancer. And it must be a Herculean effort. About 19 years of data has been analyzed with more than 400 cases of Phyllodes tumor seen at the Tata Memorial Hospital. So I think Dr. Neeta Nair is going to sort of enlighten us with all the insights that they have in management of fibroepithelial lesions, how a clinician should make decisions. Dr. Neeta, the floor is yours.
Thank you so much, sir. So at the outset, I'd like to thank both Dr. Goyal and Dr. Vaishali for this opportunity. And I will tell you that that Herculean task is actually also credited to Dr. Garvit Chitkara, who's now an assistant professor with us, but this was his thesis. And we took a year to clean it up after that again and published it only sent it again in for publication only last year. So the topic, though, says how to personalize surgical management. I'm actually going to talk about what a surgeon really needs to know when you have a patient of phyllodes. So Ruchika gave us an excellent overview of the pathologist's perspective of it. And you must understand is that when you have a pathologist like a Ruchika or we have a Tanuja, you have a lot of help in as a surgeon. And that makes a lot of difference in tumors like phyllodes, because everything that you will plan as a surgeon for management depends on the pathological evaluation that you get. So phyllodes, and I'm just going to run through this a little bit because she's already done an excellent job of this, are basically fibroepithelial neoplasia. They account for less than 1% of all breast tumors, and surgery continues to be the primary modality of treatment for a phyllodes tumor. We know of multiple prognostic and predictive factors ranging from age, tumor size, mitotic activity, but one of the most paramount factors related to local recurrence continues to be a presence of a positive surgical margin. The role of adjuvant therapy, specifically radiotherapy, still remains a little debatable in terms of there are very unclear guidelines on where we'd actually want to give it. Now, if you have a patient who comes with a phyllodes that looks like this, and a lot of us still continue to see this, I think there's very little ambiguity on what we're planning. Unfortunately, a phyllodes can mimic a fibroadenoma, not just pathologically, but also clinically. It can come as a painless, small lump in a breast. feel very benign, feel very well defined, and that's where the problem starts. So you know that this is something that's going to be common in the 5th decade. We've discussed the WHO classification, and a lot of this again depends on how well versed your pathologist is, because you need a really good and a really attentive pathologist to be able to guide you on what needs to be done next. So I'm going to just take this back a step actually, is the first thing you need to remember, and this is because we practice a very radical view on treatment of phylloids at Tata Hospital, is that the origin of the phylloids tumor is from the connective tissue of the breast. And that origin is again the mesenchyme. I will bring to your attention that both the underlying muscle as well as, maybe not the skin, but the underlying muscle also originates from the mesoderm. And a part of our treatment planning is based on that embryological origin. So what I as a clinician need to understand in the first place when I'm planning a patient with the phylloids is I need absolutely accurate diagnosis. Ruchika put that across extremely well, telling us that there is a lot of ambiguity, especially when you have a benign phylloids, in understanding for a pathologist whether this is a fibroadenoma or a benign phylloids. The more the mitotic activity, the more the amount of changes that they see in terms of I'd say stromal cellularity, mitotic activity, they're able to probably tell us slightly easier on borderline and malignant phylloids. So as is with any breast lump, it'll start with the triple test, a good clinical evaluation, relevant imaging, and some sort of diagnostic pathology. Now, most often we would choose to start with the core and not an FNAC on something like this, but the core again can put the pathologist in a dilemma because there are certain aspects that overlap, and we've already heard that from Ruchika. What you need to understand is it's extremely important to identify whether this is a benign phylloids or a fibroadenoma, because the risk of local recurrence depends on what you offer your patient as definitive management. So this is actually the same paper that she's already alluded to, which talked about the accuracy of core biopsy and erring on the side of offering the concept of an excision biopsy when there is some ambiguity. And I will say this, that we do often get a core biopsy which says fibroepithelial neoplasia. It may say favors phylloid, may say favors fibroadenoma. We go in, we discuss with the patient about a 2-staged procedure. We will go in, if they're smaller tumors, we'll probably excise them wide. If they are larger tumors, we would enucleate them and discuss a second procedure if this comes back as a phylloids. Also understanding, is there something your radiologist can do to help you? There is a very eloquently written paper which got published in 2020, which talked about sonographic features. And something you'd want to discuss with your radiologist is looking at vascularity. So just turn on the Doppler probe, look at whether there's any vascularity in that tumor. You don't expect a fibroadenoma to be vascular, so then that's probably pointing more towards a phylloids tumor. One of the pathognomic, I think, clinical features is if you have a patient who talks about having had a lump in the breast that's suddenly increasing in size. Those are fibroadenomas, having had some sort of transformation, which is sarcomatous, and suddenly growing as phylloids. So the paper also talked about that if the tumor was larger than 2 centimeters on ultrasound, there was almost a double probability of having it be a phylloids on final pathology. So once we've got some help from the pathologist, from the radiologist, and I know that this is tending towards being a phylloids, what is my appropriate surgical plan? Because please understand, this is where we still continue to play the primary role. Surgery, and the best well done first surgery, is what's going to be curative for your patient. So the questions are, do we apply rules of epithelial cancers or soft tissue sarcomas, which are en bloc excisions? Can we offer conservations, or are we always discussing mastectomies? And what exactly is a good enough or adequate margin in a phylloids? So when you look at conservation versus mastectomy, there's been a large body of data, and a lot of this actually came from the SEER database, which talked about whether you achieve a wide margin with a mastectomy or a wide excision is good enough. There is no difference in outcome based on extent of surgery as long as your margins are free. So very similar to what we do for cancers is if you can get good wide margins with a lumpectomy with good cosmetic outcome, it is safe to conserve even a phylloids. But the SEER database, of course, did show that there was only a 15% increase in conservation rates across the decade. And this was primarily because phylloids, more often than not, present as much larger tumors. And there you're then talking about replacement surgeries, or you're talking about cosmetic defects that need additional treatment. And then patients probably refuse the same. One of the biggest controversies, and I think it's just worsened this year with some paper that came out earlier this month in JCO, which talks about margins in phylloids. And when you talk about margins in phylloids, please understand that is the single most important factor for local recurrence. We've talked about increase in local recurrence across the decades and gone from 2 centimeters to 1 centimeter. We've discussed it to death even in carcinomas or IDC. In a phylloids today, as per the NCCN guidelines, a 1 centimeter margin on microscopy is what's considered an adequate negative margin. There is, however, a concept of the pseudocapsule forming projections, which is known as the pseudopodia, and that tends to be further than what is evident to you clinically or on gross, I would say. And therefore, you need a wider margin, which on pathology microscopically would potentially come negative. This is work actually that's being taken forward at the AIIMS in Delhi by Dr. Anurag Srivastav. I think one of his students is doing a thesis related to this, primarily to evaluate the pseudopodia and the extent of margins and the width of margins. This is data that comes from a chapter based way back in, I think, 2001. This is not a new concept. It's just something that we're rehashing because we're still struggling with the concept of, can we de-escalate surgery even for a phylloids? This is the paper that I was alluding to, which was published in JCO in 2020 earlier this month. Now, you will look at the fact that this paper talks about that even if the final positive margin, and this is what I talk about, in 75 patients, the final positive margin was, the final margin of excision was positive, right? So that's in 75 out of this is 550 women. The local recurrence in that group was only 2.7%. What I will bring to your attention is the largest group of that margin positive was a benign phylloids. Their malignant and their borderline were all excised to final negative margins. You must remember, which is why they have discussed and they've concluded only on benign phylloids, saying that we probably need to go back and reevaluate our concept or our need for a wider margin in benign phylloids alone. I will allude to this again when I compare it to the data we see, because I would take this with a bag of salt. I wouldn't say a pinch of salt. In a setting like ours, you need to be more careful about which benign phylloids you can leave or enucleate like a fibroadenoma versus what you would need to go back in for. So this is the paper that Dr. Goyal so graciously mentioned, which is, I think, a lot of, I would say almost all credit actually to Dr. Chitkara, where we had 433 women across the last, I think, 2 decades. And we've had, as is comparable with most other data, 40% are benign phylloids, 19 to 20% are borderline, and 30% were malignant phylloids. Unfortunately for us, a large proportion of our patients, that's almost about 35% of our patients, present with having had some excision done outside, which is invariably incomplete or margin positive. The median tumor size in this group was 6 centimeters. And I will bring back your attention to the previous paper that we discussed from the US, which talked about maybe leaving behind positive margins for a benign phylloids. Their median tumor size is 3 centimeters. You're talking about a completely different tumor pathology. In our paper, again, we were able to offer breast conservation, or I'd say lumpectomy, to almost 50% of our patients. And extent of surgery or type of surgery, conservation versus mastectomy, actually did not impact any form of local or distant recurrence. If anything, the mastectomy group did worse, but that unfortunately is because of biology, because the larger tumors, the more malignant tumors would tend to have a radical mastectomy rather than a lumpectomy. So that's not really the flaw of the surgery, but pathology or biology, I would say. On a multivariate analysis, the two things that stood out, and this was not surprising, was one, histology, meaning that the more malignant, the higher the risk of recurrence, and history of previous biopsy or previous excision prior to presenting to TATA. And when we talked about previous excision, this was patients that were incompletely treated outside. And I would stress repeatedly that that has been a significant concern and was actually what drove this audit. So we actually went back and decided to look at only the women that we treated at TMH de novo. So that was 231 women. Again, median tumor size is still about 5.5 centimeters. Distribution of histology was fairly similar. And at a median follow-up of 44 months, we found a DFS which was as high as 92%. And this, we implore the same concept comes from a good wide excision. Now, I will bring your attention to, and I haven't brought that up, is there was a paper published by Dr. Anurag Srivastav in about 2011, 2012. And this was after he had spent a year of his sabbatical from AIIMS at Tata, discussing the concept of a very radical en-bloc excision, which is what we practice at TMH. What happens is that you always excise the underlying muscle. And this is what brings us back to the embryology, which I mentioned to you, is the phylloids comes from the mesenchyme, the muscle comes from the mesoderm, and it's very similar origins, because of which we tend to excise overlying skin, underlying muscle as a complete block of tissue without raising flaps. Now, I will say that we do this with impunity across all histological subtypes, and it does give us new evidence to suggest maybe if you have a smaller tumor, larger breast, can you leave behind overlying skin and just do a good wide excision only for a benign phylloids? Needs to be reevaluated, and I don't think we have enough information to do that. We did, however, of course, notice that the number of recurrences between the treated outside versus not at TMH was much lower. Now, this is where I'm going to compare the data from the New American paper, which was across, I think, 11 different institutions versus the Tata data. And when I've looked at only the group that was treated de novo at TMH, which was 231 women. So the tumor size is almost double at Tata, which is what's expected. We see a slightly higher number of malignant and borderline tumors as against a benign tumor. And you need to understand again, and I'm not questioning the pathology, but it takes a lot of, I think, a lot of interest from a pathologist to clearly define a borderline phylloids, a benign phylloids from a cellular fibroadenoma. And it's easier to err on the side of calling a cellular fibroadenoma a phylloids and then saying that your outcome looks very good. So they've seen a local recurrence of only about 3.3%, as against a 5.6% that was seen at Tata. But again, that comes primarily from the fact that we have more malignant phylloids tumors. Trying to understand the difference between the extent of surgery, we looked at the patients, that's 231 women treated de novo at TMH versus those who were treated outside and had no recurrence when they presented to us. And there is a stark difference between the DFS of these two groups, which primarily points to the need for accurate preoperative planning and a good wide excision with clear margins as your first surgery, which is what's going to prevent any further recurrences. So surgery, fortunately, still remains the cornerstone of management. And with the questions that remained unsolved, I think that for now, what we do know is for borderline and malignant, en-bloc resections with wide margins of at least 1 centimeter, overlying skin, underlying muscle continue to be our standard of care. For benign, yes, there is space for a debate, but I think we need slightly better evaluation of the tumor by the pathologist. Conservative surgery is, yes, an option as long as you get good cosmetic outcomes. Wide margins for local control still continue to be 1 centimeters. And fortunately, the role of lymph node assessment is currently not evaluated. You will see, and especially with those large, big phylloids, which are those 15, 20 centimeters with a little bit of necrosis of overlying skin, you will see large lymph nodes. Err on the side of trying to send that for frozen section, because a lymph node involvement, even with a sarcomatous tumor, is under 5%. So do not increase the morbidity by doing a clearance just because you have large nodes there. Often these are just reactive nodes related to the fact that your patient has had some infection, or I would say these are just infective lymph nodes, reactive lymph nodes because of that overlying tumor. sorry. So which is what takes us to the first thing, and this is, I think, paramount for all of us as surgeons or oncologists, is you want to be able to reduce the risk of further recurrence among your patients. And what takes you to that is what are the factors that define your risk of recurrence. And I will repeat this again and again, is the negative margin is your first defense for your patient, because a positive margin is your highest risk of local recurrence. Every single time a patient comes back with a recurrence, you will see a heightened risk of malignant transformation, and a benign to a borderline to a malignant, and you want to be able to avoid that. Understand that with 6-centimeter tumors, we're already talking about a slightly lower health conscious population. Leaving these benign phyllodes alone without negative margins is not something I think we're ready for, unless you really have a big breast, small tumor, where you can get away with a smaller excision, where your patient's going to be very religious for her follow-up. You could possibly follow those guidelines. Otherwise, it continues to be at least a 1-centimeter margin and a good en-bloc excision for a radical and a borderline phyllodes. Taking that forward, to whom would you send across for adjuvant radiotherapy? And I think we'll take a lot more of this into the panel. But today, the role of radiotherapy is primarily for women who have malignant phyllodes that are greater than 5 centimeters, or women who present with recurrent phyllodes. We unfortunately, however, see 20, 15-centimeter borderline phyllodes, and we don't have guidelines for that, but we do have a discussion with our patients. These are personalized concepts that are brought in. We would probably discuss and offer radiation therapy to these women, but I would turn around and say the same thing, is that the evidence does not exist, and that's honestly a discussion you're having with the patient, because large borderline phyllodes to the point of 15 centimeters, we really don't know what most appropriate adjuvant therapy for them would be. Chemotherapy today is still reserved only for the metastatic setting, and unfortunately, a patient who presents with the metastatic phyllodes continues to do fairly badly with a very short progression-free survival. So what I can tell you today as a surgeon, and having worked fairly long on the concept of phyllodes, is your first defense is a good pathologist who helps you with appropriate preoperative planning and good wide en-bloc excision with wide margins which are negative irrespective of histology. Recurrences that tend to be related to the initial surgery and the extent of surgery can be re-excised with wider margins with local flaps done there. And any phyllodes that recurs is going to come back with a slightly higher or borderline transformation, which is not something we want to put your patient through. So, and they tend to be very unpredictable in their metastatic potential. So you want to follow up your patient every 6 months, at least for the first 2 to 4 years. Thank you very much.
Thank you, Dr. Neeta. As usual, a very elegant talk. And I would say definitely the concept that you have formulated of en-bloc excision with skin and underlying muscle is something which I believe would be debated in the panel, whether the other surgeons on the panel, do they subscribe to the same approach or not? There were many comments or questions within the chat box. We would like to take them towards the end of the panel. Sure. And for the panel, we have to moderate the panel, my colleague, Dr. Vaishali Zambre, who's a senior consultant in surgical oncology with a primary interest in breast oncology at Max Vaishali in Patparganj. Besides Dr. Neeta and Dr. Ruchika, we have Dr. Rajiv Agarwal, who's a senior consultant in surgical oncology at Medanta, Dr. Navneet Kaur, who's a director professor of surgery at GTB Hospital and University College of Medical Sciences, again with a long-standing interest in the field of breast oncology, Dr. Asha Reddy, who's a consultant at Chennai Breast Clinic. And we have Dr. Charu Garg, who's a director in radiation oncology. There were some questions about chemotherapy adjuvant. Unfortunately, we haven't had a medical oncologist on the panel because we thought there's not going to be too much of a discussion on it. and we'll take Dr. Neeta's word for it that primarily chemotherapy is restricted for the metastatic Phyllodes tumors. But other than that, we are going to have a lot of debate among the surgeons and where and when to use radiation. Dr. Vaishali, over to you.
Yeah, thank you, sir. I once again welcome all my esteemed panelists, and I'm sure after Dr. Neeta's talk, it's going to be very tough for me because she has deflated all the air I had actually gathered in my presentation. But nevertheless, it's going to be interesting listening to different views and different clinical practices. So as we have seen, and Dr. Ruchika also excellently alluded on the fact that these fibroepithelial lesions actually range widely from cellular fibroadenomas to the metaplastic carcinoma of breast. And in clinical practice, although these fibroepithelial lesions represent a smaller percentage of breast lesions, but we do come across a variety of patients, variety of age groups, and I'm sure all the patients pose equal challenges for a clinician as to how to investigate and diagnose as well as manage this patient. So in this panel discussion, we're going to have some real good challenging cases as well as those patients who have been actually shared with me by my friends who are doing or pursuing MCH at UEA. And all these patients have been photographed with their prior consent. So as we know that these are the features which also help the pathologist to differentiate between a benign to a malignant and borderline phyllodes. And as well as these are the features which probably are responsible for prognosticating or assessing the risk of recurrence after the surgical excision. And the concerns which we as clinicians face when we manage Phyllodes tumor are that there is a large subjective variation in interpretation of histological features, and there is definitely a suboptimal correlation between the histological classification and clinical behavior. We sometimes come across very benign looking, clinically benign looking tumor, but it turns out to be malignant. And occasionally the borderline Phyllodes tumors, if even after a good surgery, they sometimes tend to recur or some occasionally metastasize also. With this background, I would actually simply start with a common scenario which we come across. Say, for example, this is a hypothetical case. Say we come across a young lady, say 30-35 year, and who presents with a painless lump in one of her breasts for say couple of months, say 6 months, and it has not really progressed. However, on ultrasound, it shows some differential features, whether it is a fibroadenoma or a phylloid, and even core needle biopsy shows that there is a differential of either a fibroadenoma or a phylloid. So in this a commoner scenario, I would like to ask Dr. Rajiv Agarwal first. Sir, how do you approach this patient surgically? Would you be, because as Dr. Neeta has very nicely alluded that probably the margins, the negative margins are the only factors which are helping the patient to have a good future as to prevent recurrences, and the outcome of the surgery is going to be good in case if the margins are negative. So how do you approach? Do you regularly go for a 1 centimeter margin, or would you rather enucleate, or how do you approach such a patient?
No, in fact, before the surgical approach, I would like to mention that if my radiologist gives me a doubt of phylloid tumor, even if the tumor is palpable, I would like to go for an ultrasound guided needle biopsy, because that will be from the solid areas, because phylloid can be cystic areas and the solid areas, and preferably the core needle biopsy from 2 different places, because pathologist, as everybody is telling and we all know by experience, that preoperative pathology can give us a reasonable amount of guidance for the planning. And second thing, I don't think there is any confusion today that a clear margin of at least 1 centimeter is important in phylloid tumors. Of course, by mistake, if somebody does that it is 5 millimeter or 2 millimeter or 1 millimeter, then the definitely question comes that what is the final histology and should we go for a re-excision or not? But if we have the diagnosis of fibroepithelial tumor suspecting a phylloid preoperatively, I think a 1 centimeter margin is minimum that I should try to achieve.
Yeah, so I would now move on to Dr. Navneet. Ma'am, would you agree to Dr. Rajiv, or you take a different approach to all the patients who clinically probably look like fibroadenoma, or there is some doubt about phyllodes? How do you approach such a patient?
Yeah, Dr. Vaishali, I think this is a frequent query, and I would agree with all the previous speakers in saying that this is a very unpredictable tumor. We have difficulty in having a good, accurate pathological assessment because of the limitation in criteria which are there for its definition, and also the limitation of getting a, because these tumors generally tend to be large. So even a core biopsy from say a 6 by 6 centimeter tumor will represent only a small area, and it may not be the true diagnosis for that particular lump. But I would say I am not as concerned about a very radical surgery in one go for fear of recurrence, because if you look at the data, the benign tumors, the recurrence rate is about 10 to 15%. So even if you have not done a very radical excision for a tumor which is reported preoperatively as benign, the chance of a recurrence is going to be 10 to 15%, which you can very closely monitor and address. So I would say the usual approach to a tumor which is suspected clinically, because somebody is 35 plus, you would be thinking more of a phylloids than a fibroadenoma at that age.
Right.
And the ultrasound or the imaging that we use is suggestive of a possibility of phylloids. Just in the first go, I would be taking out the tumor with a decent margin, without wanting to be very radical with the surgery, because at least 70% of these ladies probably will be fine with that much surgery.
Right. Yeah, I think so clinical, radiological, as well as the coronatal biopsy gives us an idea as to which patients can be managed with simple excision or which patients do need a 1 centimeter margin. So triple assessment is definitely going to be the clue for us to plan the surgery. Dr. Ruchika, are you there?
Yes, ma'am.
Yeah, so although you have covered in your talk, but I would like you to please repeat for the attendees who have joined us later, as to what is the role of IHC in differentiating different grades of phyllodes. Can you just briefly repeat for the sake of those who have joined later?
So, ma'am, IHC honestly does not have any role in differentiating benign, borderline, and malignant.
Yeah.
To differentiate benign, borderline, and malignant, we have to base our thing on histological criteria. And those are stromal atypia, stromal overgrowth, mitotic figures. There are different categories: less than 5 per 10 hyperfield, 5 to 9, more than 10 per 10 hyperfield.
Yeah.
The border of the tumor, whether it is a circumscribed border or a permeative, infiltrative kind of border.
Right.
And presence of malignant heterologous elements. So if you have malignant heterologous elements like your chondrosarcoma type or a rhabdomyosarc or an angiosarc, any of these mesenchymal elements can be there in malignant phyllodes, except a liposarc. So basically, IHC does not help, but you have histological criteria, and these have to be seen. Multiple sections have to be obviously examined, and these are also subjective criteria. What I mean, count of like mitosis and atypia, what I may feel is mild, it might be moderate for you. So there are these 5-6 criteria, and that's why that the Singapore model, which gives the recurrence score, they take only 4 criteria, which they say is important. And margin positive is one of them, and you have atypia, mitosis, and stromal overgrowth. Yeah. But after that also there is an overlap. So one should grade it on the worst component of the tumor, but provided it's more than 10%.
Right. Dr. Neeta, I would like to ask you, as Dr. Rajiv said, that even though these lesions are palpable, would you still recommend? Hello?
So I would agree with what Dr. Rajiv said, is that
Yes.
because phylloids tend to have cystic spaces, you would want to be sure that you're biopsying the most appropriate area, and a USG guided biopsy is probably the best way forward.
Right, right. So with this background, then we would like to come to the cases. As you can see here, you all have come across young women with rapidly progressing tumors in one of their breasts, and many women, actually ladies, they come to us at a very young age when they are yet to be married, and when they are actually when their parents come to us with such a problem, and obviously their concern is how to best manage these tumors without sacrificing the breast and giving a good cosmetic outcome. And occasionally their expectations is about the functional outcome of the breast also. So I'm going to present one case. The first case is a 27-year-old lady who came recently to us, and she is about to be married in a couple of months. So she presented with a rapidly progressing lump in her right breast. And when she came, she definitely had pain, redness, and edema of the skin, which she had for last couple of days. There's no family history, and these are her clinical pictures. So when she came, she had a largish lump in the right breast with dilated veins on the visible on the skin, and this was the extent of the tumor. The areola also, you can see that the skin and the nipple areola also has been very significantly stretched, and there is skin edema. And in this picture, you could also appreciate the erythema as well. So would like to start off with Dr. Neeta as to how do you, whenever you come across such a patient, how do you work up? How do you start your diagnostic workup?
I think again, it will be the typical triple test, go to clinical evaluation like has been done in this lady. Because she's 27, we'd start with an ultrasound and an ultrasound guided biopsy if there are cystic spaces within this, because I think the clinical DD would first be a phylloids for something like this. I think that, the fact that she's got a much larger breast on one side, if it's very rapidly growing, your concern is whether this is a borderline or malignant phylloids, and you'd want to get appropriate diagnostic evaluation with pathology.
Right.
Start with guided biopsy.
Yeah, sure. So this was her ultrasound picture. She had got an ultrasound done elsewhere. And I'm sure Dr. Neeta would not agree, but I would like to ask Dr. Rajiv and Dr. Navneet, would you be doing anything else beyond ultrasound?
I think our decision is largely going to be what we see on biopsy. This generally suggests this is a large tumor with some areas which are heterogeneous, some vascularity. So the picture is very suggestive of a phylloids, but we cannot comment whether it is a benign or a malignant, at least on ultrasound. MRI has been used by many people with some criteria to say that this tells you a little more about the probability of being malignant. And maybe also you would like to know the status of the chest wall, that if it has gone deeper, so that would be helped by doing an MRI of the breast. But I would say the final diagnosis and approach would be dependent upon having the final histopathology, the histopathology based on a coronary biopsy. So ultrasound tells us a large tumor. It could be, it cannot be really commented upon reliably. It's a borderline malignant or malignant. Generally, even despite large growth, you would see many reports, the size of the tumor doesn't translate into the histopathological variant. You will see very benign tumors growing very rapidly.
Yeah.
So size, even though it has grown rapidly, doesn't alarm me as much to its malignant potential. But if core shows some suspicious lesions, then obviously a metastatic workup for a malignant potential would be an added on investigation that would be required.
Yeah. Dr. Rajiv, any comments on the role of MRI?
I don't think MRI has too much of a role in these cases. Ultrasound guided biopsy, as Dr. Neeta has already said, if clinically my tumor is not fixed to the underlying muscle and good ultrasound by a dedicated breast radiologist, I think, can give you as much information as MRI in these cases. So MRI, one can do it, but I don't think it is going to add into decision making too much.
Dr. Asha, your
Yeah,
comment, please.
so we don't do MRI routinely. So I don't think in these cases MRI is going to add much information. So a good ultrasound would be adequate.
Yeah. But here in this case, it was done. And you can see that, I mean, obviously, other than the extent of the disease and the heterogeneity, which you can see here on the MRI, it has not added any significant value. And I also agree with all of you that probably ultrasound, a good ultrasound and a good corneal biopsy is what is enough to begin with. And in case if it turns out to be or reported as malignant, then probably we have to do some metastatic workup. Here in this case, although we have discussed that ultrasound guided biopsy is what it should be done, but here I had done a biopsy without ultrasound guidance. And when I did the biopsy, I could see that the cores which I was getting were not actually the good cores which we usually get, and they sink at the bottom of the container. And despite that, because there were some financial limitations, I went ahead and did a biopsy myself. But the histopathology was reported as benign breast parenchyma displaying mild adenosis and stromal hyalinization. And this is what is the the images which my pathologists have sent. So Dr. Ruchika, can you tell us as to I mean, how do you interpret this? And obviously the patient was not willing for a second biopsy. So how do we go about it?
So honestly, just seeing these two, they are just scanner views, but this looks like benign breast tissue, and I will not be able to even call it a fibroepithelial neoplasm with increased stromal cellularity. Seeing these, we should remember these neoplasms, however large they are known to be very heterogeneous. So where exactly the biopsies hit and what are we seeing can actually vary. So in this, I agree with the pathologist. There's not much information that they can provide here.
Right. Dr. Neeta, there has been a question actually which has been sent to us by one of the attendees, and he wants to know, because when we look at the size, and we are going to probably approach this in a definitely a radical manner. So would you insist on a rebiopsy, or is biopsy really needed when we know that occasionally the pathologists are not able to tell us whether it is a benign or a malignant or a borderline? And when we look at the extent of the size of the tumor, we are going to be a bit radical in our approach. So do you insist that a biopsy should be done in all the cases, or repeat biopsy in this case?
So I would think that in this case, I would probably ask for a repeat biopsy, because our definitive plan is going to involve some sort of reconstruction if you're conserving that breast. Because you're going to excise a fairly large volume of the tumor and then the breast tissue adjacent to it. The option, of course, is put your pathologist on the spot and even try a frozen section with it. They may kill you for that. Our pathologists definitely want to murder us when we try stunts like that.
Right.
But I think what happens, and which is what we need to be very clear about, is a lot of this discussion needs to be with the patient in confidence, that this is not as simple as a one-step procedure. You don't want to, so we've had situations where, you go in, you do a very wide excision, it then comes back even as a PASH or a dermatofibroma. You don't want to have situations like that, and then having done very wide, large reconstructions.
Right. In fact, I did discuss that we need to have a repeat biopsy, and that too an ultrasound guided biopsy, because I was repeatedly getting such, inadequate cores. But the lady in question was not willing, and there was some financial limitations. So we planned her surgery. And obviously with the approach that it has to be a two-stage procedure, it cannot be a single-stage procedure. And we also discussed about the possibility of getting a diagnosis on frozen section. But as you rightly said, the pathologist said that probably they may not be able to add any further value to what and it may not really change our approach. So we planned her surgery. This is what has been done for her. Here, I would actually want to know from all of you whether this approach was the correct way of doing it. We did it by inframammary approach. And as you can see, the extent of the tumor was such that it was even going beyond the nipple areola complex. So there was hardly any, margin on the anterior aspect. So just barely managed to remove it from the undersurface of the skin, and laterally and medially, yes, there was some margin which we were able to take. But this is what, would you like to agree with this approach, Dr. Asha?
Looking at the imaging and the history of it growing rapidly, and there's a lot of increased vascularity in ultrasound as well. So I think getting such a close anterior margin was probably not the right choice. But I would have probably preferred to remove a little bit of skin at least over the tumor.
But the problem is the area of contact with the skin was at a very wider area. So how to, because Dr. Neeta in her paper has also written that a very radical approach and excision of the skin over the lump and the underlying muscle is what has to be the approach
would have had to
in such a
remove
case.
skin and probably planned a flap for her.
So I think if you ask
Dr.
me what
Navneet?
I would have done, Vaishali, regarding
Yes.
the first question, which was asked whether you would want a repeat biopsy or you would. So I think as we discussed, everything has to be discussed with the patient and given a picture. In the first scenario, since we had a rapid growth, I said already, and this is my experience, is not something which should be making us think it is malignant. But even benign can grow very fast.
Yeah.
The skin changes he had probably was because of the local effect of the vascularity, because of the pressure of the rapidly increasing tissue.
Correct.
And the MRI picture was showing just a localized thing, no invasion beyond the confines.
Yeah.
So based on that, I would say, and the biopsy report, because core biopsy gives you a representative specimen. If it is something malignant, something would show up in the section that you have taken. So I would have thought that, okay, with the current ultrasound, MRI, clinical, as well as the pathology saying it benign, I take it as a benign phyllodes. And my approach probably would have been to do a reduction mammoplasty kind of an incision and excise the skin. You can see the areas which was under pressure is discolored. And later on, you might have had that skin loss also. A patch from there would have probably necrosed. So I would have taken a reduction mammoplasty, Weiss pattern incision, excising the skin which was most stretched out over the tumor. So that was the medial lower pole, and do a reduction mammoplasty incision, and then go inside, remove the tumor with a reasonable margin. So from the skin side, when it was too close, that skin would have got out with the mammoplasty incision, reduction mammoplasty incision. And the other areas, you should be able to get a 1 centimeter margin minimum. And then subsequently, once the entire histopathology comes and the processing is done completely, you can decide whether there is any heterogeneity, there is any lesion which has not been picked up on core, and go for a second surgery, maybe then a mastectomy and a reconstruction as discussed with the patient, if something like that is reported in the final histopathology.
But if you do a reduction mammoplasty and if the anterior margin is very, close to a large extent of the tumor, then how would you address that issue? Because you have already...
in the reduction mammoplasty, the entire skin can be excised. If you were to kind of make a drawing, the entire lower medial pole skin can be excised along with the, because you see there's a lot of redundant skin. There's a folding. So that skin is extra. That could have been easily taken out with the specimen. And also this would have taken away the possibility of skin necrosis subsequently because the skin flap was too thinned out. It was already under stress, as you saw. Changes
so in this area, it was definitely very, very close. And you can see that there is some discoloration also. What about the nipple areola complex? Because she is a young unmarried girl.
I think I would have preferred to save it, because as we know, it is not primarily a lesion which is affecting skin either by infiltration or is generally a pressure. If at all it is involved, it is pressure necrosis. So saving nipple areola complex is should be aimed for, and especially when it is not obviously malignant. If it is a benign histopathology, benign core, benign MRI, benign ultrasound, then probably in the first go it should be preserved. I think patient should know that there may be a need for a redo surgery. And in that case, probably we will be more radical. But first time we will try to preserve as much skin nipple areola for a good conservative cosmetic outcome as possible.
Yeah. Dr. Neeta, any different approach?
So I would think that if you don't have diagnosis on whether this is benign or malignant is your first concern.
Yeah.
Needing to get at least a 1 centimeter margin, even for a benign, is what we would follow, and specifically for such a large tumor. Unfortunately, your anterior margin in this is going to be positive because you can see the tumor right there. So we would excise all that skin which is close and positive. We would, if it was malignant or borderline, excise the underlying muscle. And if the nipple areola was part of the overlying skin, I think we would end up taking it. But if this is a benign phyllodes, very low mitotic index, you want to discuss it with the patient, keep her on very close follow-up for the nipple areola. That's something that can be re-looked at. But I think that would depend on what the final pathology comes back as.
All right, now let us have a look at, these are her images, because she ended up with inframammary crease incision, the excision of the tumor. And as you have rightly guessed, it has been reported as a borderline phyllodes, and with the mitosis of 8 to 10 per 10 high power field. And the margins are unremarkable, with nearest margin is 1 millimeter. So when I discuss with the pathologist, the anterior margin, as you have rightly guessed, is close, or very, very close, in fact. So now the question is what to do next. So resurgery, what type of resurgery?
Resurgery, though, I'll have everybody with me on this. But we go back and
yeah.
No question.
So now that the incision is at the inframammary crease, how do you do it?
You excise all that skin. So we see quite a few patients who come in with tunneled excisions. You just go wide on what was the, fortunately, if you've done the procedure yourself, you will have either a pre-op photograph or some marking, that diagrams that you will have with you, good wide excision of that skin and underlying muscle. So that would be our policy, and it's worked for us.
Considering the recent JCO publication,
that's only for benign. That's what I repeated multiple times, is that if you see the re-excision, the avoiding re-excision, not needing negative margins, is only in a benign phyllodes. And their benign phyllodes also border on being cellular fibroadenomas.
True. Dr. Charu, this lady does not agree for resurgery. So is there any way radiation can compensate for the shortcomings?
No, I think since this is a borderline phyllodes, a resurgery should be done. I mean, the patient has to be convinced that she is young, and radiation can possibly not compensate, for the good surgery.
Absolutely. Dr. Rajiv, any comment on your side?
No, definitely. She needs a resurgery. I don't think there is any role of, because it's a borderline case, the role of radiation otherwise is a debatable issue. And only in certain selected indications, as Dr. Neeta said, if the mitosis is more than 10 or 15, if the tumor is recurrent, if the tumor is very big, only then those cases radiation may be a role, but not in an intermediate case where the tumor is so big and margin is very, very close.
Absolutely. So we all agree that this patient needs a resurgery, and that is probably her going to be the only option for her, considering her age as well as the clinical presentation with which she has come. So now we move on to case number 2. She is a 36-year-old lady, and she had a excision of left breast lump in 2018, which was done elsewhere, and she presented with a periareolar scar of previous surgery. The histopathology of that tumor was reported as cellular fibroadenoma. When she came to me a few months ago, she had noticed a lump in the same breast 4 months ago, and then that lump definitely progressed very rapidly with the clinical presentation of this. So she is 36 with a recurrent tumor in the left breast, and this has definitely progressed very rapidly. So this is what is the clinical picture. Dr. Neeta, I would like to ask you whether you would approach this recurrent tumor with a different angle.
Triple test stands. continue to do the same.
Yeah.
Unfortunately, this may just be one of the perils of a pathologist having probably misnamed the previous biopsy, which is what helps if you have a pathologist like Ruchika or Tanuja on board, then you have a better chance of diagnosing that first tumor to start with.
Right. Dr. Asha, would you be, will it be imperative for all of us to do a review of the previous pathology? Will that make a difference?
Probably, but also we can biopsy the new lesion that has come. So that's going to tell you what the recurrent lesion is anyway. So then you're treated based on that. It's just, I think, more that where the location was, they've tunneled. So you want to make sure you remove all of that area as well. So to know where the tumor was probably would also be important at this junction.
Yeah, and in this particular patient, because she's recurrent, again, the imaging approach is going to be the same, or is it going to be different? Would you be doing MR in this patient?
No, I don't think MRI is going to add much because you're probably going to remove the underlying muscle if it's involved and it's a recurrent tumor anyway. So I don't think anything else differently imaging-wise for the breast is going to be needed.
Vaishali, if I may, the only thing that I would probably add is that if your biopsy this time comes back as malignant and it's a recurrent malignant tumor, I'd probably add a CT chest just to make sure that it's not recurring.
Yeah, surely.
Vishali, I think I would like to add one or two things here.
Yes, ma'am.
Her first report was cellular fibrilloma. I am sure it is imperative to have a look at that previous histopathological assessment. But at the same time, I would say even with best of experience and even when Dr. Ruchika made a presentation, it may be difficult at times to differentiate a cellular fibrilloma from a benign phyllodes.
Yeah.
Because they so closely mimic. Unless you have the entire specimen out, probably you will not be able to comment on that. So they are kind of a progression of a similar pathological feature. That is why there is a term of benign fibroepithelial neoplasms when there is a ambiguity between kind of designating one as a cellular fibroadenoma versus benign. So I presume that that report, even if it is reported as cellular fibroadenoma from outside, would be at least will have some validity. So it might be, and cellular fibrinomas are also known to recur. So recurrence is not only an attribute to phyllodes, even fibroadenomas recur. So obviously, we have to keep a possibility of a higher grade recurrent lesion than what was reported earlier. So it can be a borderline, it can be a benign or a malignant. So that is definitely going to be based on a biopsy. And I think for a redo surgery, if you, as a routine, I think very few centers will excise the muscle in even for a redo surgery unless there is an indication. So that kind of a radical mastectomy or a radical excision may be practiced in some centers as a institutional protocol, but that is not what is practiced worldwide. So getting a clear margin definitely is important. You have to be a little more radical when you are going in again. I think with a little more evaluation of local disease by an MRI, I think when we are doing the redo surgery, it's probably going to help us more in planning whether we have to be so radical to go to the muscle or we can just still get a margin, good margin without going that deep.
Right. So it was more superficial and stretching the skin, but it was mobile on the chest wall. So this was her ultrasound. And on ultrasound, it was reported that there are 2 tumors. Although clinically I could feel only 1 tumor, but there were 2 separate tumors reported on her ultrasound. So we did a core biopsy and it was done under ultrasound guidance. And it has been again reported as benign fibroepithelial lesion and possibilities are fibroadenoma and benign phyllodes tumor. But since there was a confusion about whether we are dealing with 2 different lesions or 1 single lesion, MRI was done. Although I'm sure all of you would agree that MRI probably may not add any significant value. And on MRI, it was reported that there is only 1 tumor and a tumor of 13 centimeter. And it was involving all the quadrants of her left breast. However, this lady was not willing for mastectomy. So this is what was actually planned. So would you, Dr. Neeta, any comments on the surgical approach or what would have been your surgical approach for her?
So again, if you're still ambiguous about whether this is a fibroadenoma or phylloids, you're going to discuss the two-stage procedure with your patient. If this comes back as a phylloids and it's recurrent, we will definitely go back in and excise all of that en bloc again.
You mean mastectomy?
So with her, because I think what your imaging seemed to suggest was that it was involving all quadrants.
Yeah.
Yes, she will unfortunately end up needing a mastectomy.
Dr. Navneet?
Do a radical mastectomy if it's a recurrent phylloids.
Yeah, I think it's just, I think if we keep looking at the MRI film, we can go back to the MRI film. This is very well encapsulated, right? The underlying muscles and tissue planes are not involved. Removing this tumor would mean removing almost 80% of the volume of the breast. So you will be left with very small amount of breast tissue per se. So obviously, if she wants a cosmetic thing, you have to do something more to add to the volume. Otherwise, for a benign phylloids, a recurrent surgery can be a excision, white excision. This again is what is in the guidelines of different centers. Since my center is not a high volume, so I rely on what is available as a evidence in the literature. TMH have their large data, so they can probably have their own guidelines. But if I were to go by the guidelines which are published, for a benign phylloids, for a recurrence, you can still do a wide local excision without resorting to a mastectomy. So probably I would do a wide excision again with a wider margin. And maybe if the residual tissue is too small, then advise her having a mastectomy and a reconstruction, or simple mastectomy and subsequently a second stage reconstruction. So there can be multiple options. But she should know that post lumpectomy, she will have very small breast. So if it is not worth preserving for the sake of cosmesis, she can have a simple mastectomy. Probably that will keep her options or chances of having a recurrent disease much lower. And if she is concerned about cosmesis, she can be considered for a reconstruction 1 to 2 years down the line, when we have seen that this is the time when there's a most likely probability of a recurrence. So they recur normally in the first 1 or 2 years. If that goes safe, then she can have an option of reconstruction.
Dr. Vishali, I think I would like to ask Dr. Neeta the role of removing the underlying muscle when there is no imaging documentation of involvement. So what is the basis for this recommendation?
So one is the embryological development of the muscle and the connective tissue of the breast. But in most tumors, like we said, unless you have a small tumor where your margin is going to be wide, most tumors, and specifically of the last 2 cases that you've seen in this panel, the muscle will form one of your margins. And you will not get an adequate 1 centimeter margin for something like this, because in your MR, it's even sitting on the muscle.
Say one thing about embryology is, as we know, that the origin of the breast is from the skin and subcutaneous tissue. So probably the pectoral muscle embryologically is not directly related in terms of the layer from which.
So agreed, sir.
Unfortunately, breast is a modified sweat gland, so we should not.
Yeah, that's what I'm saying. So, and the second thing is, when we talk of say margins in terms of say 1 centimeter margin, now generally there's a concept in orthopedic oncology also that a layer of fascia can be considered as equivalent to say a 1 centimeter margin when there is no layer of fascia.
Agreed.
So from that point of view, wouldn't it be okay to, if you have...
We've unfortunately seen the kind of recurrences without that excision of muscle in these large tumors. And I think that, which is why we found that it is simpler to not compromise on the oncology, take out the underlying muscle, not depend on that thin layer of fascia, not breaching it. Like I told you, there are pseudopods which will be present in a phylloids, and those pseudopods infiltrating the margin, if in a malignant phylloid stretch into your muscle, you have a very high risk of local recurrence. And I don't think that that's something that we leave for the patient.
So can you clarify how many of your patients of a large size land up with, say, a flap reconstruction?
So it would depend on a patient's choice. One is if they are amenable to mastectomies, if they are large ptotic breasts and they're amenable to mastectomies, they will choose to have either a mastectomy with or without a reconstruction. It's difficult to pinpoint a number on how many of them need a free ALT, because a large proportion of that actually ends up being the recurrent cases.
Okay.
So,
please, Dr. Vishal,
yeah. In fact, this lady was also counseled about mastectomy, considering the recurrent setting as well as the breast volume. But again, she was not willing for a mastectomy. So, and at the same time, since we did not have a malignant report in the core needle biopsy, it was very difficult for us to convince her to go ahead for mastectomy. So, Dr. Neeta, how do you counsel the patients, because you also must be coming across such young women who
Agreed. So I think that a lot of it depends, and this is for any tumor, is it depends on the conviction with which you believe that it's okay to or not to leave behind that tissue. For a recurrent phylloids like this, I think it's very difficult for us to be able to tell them that you can get away with leaving behind a thin rim of tissue. It's not going to be adequate. This is not something that will leave behind adequate amount of tissue. It's going to amount to a mastectomy with the entire skin excised. So a good reconstruction instead can be offered. We've actually published some work on reconstruction awareness also, and I think Dr. Vani had presented that in the Women's Breast Cancer Conference earlier in the month. If you look at it, a lot of it really depends on getting other patients involved, showing them videos, showing them images. It's about how you counsel your patient and how you gain their confidence on a reconstruction.
Right. So, however, in this patient, since there were many concerns and she did not agree to mastectomy, so we have done wide excision of this tumor. Although, as you can see, the extent of the tumor is such large that wide excision again led to some close margins. So this is her final pathology report. Again, it shows, again, there is a differential which has been given as to benign phyllodes and cellular fibroadenoma. Dr. Ruchika, if you could read the, the detail of the histopathology. They've written that it is a fibroepithelial lesion with predominantly pericanalicular and intracanalicular pattern and mild increase in stromal cellularity. All margins are free. However, you can see below here that three of the margins are closed, and there is no stromal atypia, no increased mitotic activity, or no stromal overgrowth here. So in this scenario, when it is again reported as benign phyllodes oblique cellular fibroadenoma, when we go back to Dr. Neeta's approach of doing a radical surgery, if we look at her, post-surgery picture, this is what, because the tumor was very close to the nipple areola, the part which has been removed now has led to such a deformity in her breast. So in this situation, Dr. Rajiv, would you be agreeing to go ahead with a resurgery for achieving good wider margins, or what would be your approach, considering that it is again reported as a benign phyllodes oblique cellular fibroadenoma?
See, whatever it is a recurrent tumor.
Yeah.
So patient, first thing, I agree with Neeta that patient has to be counseled, because if we are doing a conservation surgery, there are very, very high chances of recurrence, whatever it is, whether it is a cellular fibroadenoma, whether it is a benign phylloid. If you see the MRI pictures, there's a lot of skin area, the tumor is fixed to the skin. So whether we should be remove the nipple areola complex in this case or not, we can always do a reconstruction of the nipple areola. Once the patient, though it is a cellular fibroadenoma and now final diagnosis, but the margins are closed, patient has to be counseled again that if we do not do a resurgery, there are very, very high chance of recurrence. So everything depends upon the counseling of patient, because I agree that many times young patients, even in cancer, sometimes they don't agree to mastectomy. But in cancer, we are very clear that either mastectomy or go somewhere else. In benign phylloid or cellular fibroadenoma, we have to counsel, and depending upon what patient wants, but we should be very clear and document it. That's very important today, medical legally also, that we should document it, that patient will be very, very high chance of recurrence. Ideally, a resurgery. If not, we have to document and close follow-up.
Yes, ma'am. Dr. Navneet.
Yeah, I think a few points I would like to make. Her repeat biopsy of the entire specimen shows a benign pathology and a benign phylloid. All the margins are you can call them close, but they are not positive, right?
No, they're not positive.
Yeah, even the definition of margin is being revised. And if you look at many recent pathology publications, and I think your pathologist on the panel might agree with me, that they're saying a 1 millimeter, unlike a tumor on the ink, which is for the invasive breast cancers, here a millimeter of margin, 1 mm is being taken as adequate for benign phyllodes. So as per that criteria, which is by the, I would say, different societies practicing breast surgery, none of these are positive, right?
Yeah.
So she doesn't have a positive margin, she has the benign lesion. And if you look at the birth data again, the probability of a recurrence is not more than 10 to 17% for benign phyllodes. So she has that much chance of recurrence. So I think I would explain to her what data says, and this is what my approach would be, to keep her under observation, follow up, and not go for a radical surgery. The second point is the cosmetic outcome, which is looking quite bad, which again, I would say, if I were to operate in the first go, I would have done a reduction so that the entire redundant skin is excised and you achieve a better cosmetic, better skin envelope, which is kind of titrated to the size of the remaining breast. So excess skin should have been excised along with the primary tumor in the first go, so that there was no need to do a redo surgery for cosmetic purpose. And even for oncological safety, by what is the world standard and what of the most of these guidelines will tell you, this doesn't qualify for any radical surgery or a very high rate of recurrence. If you look at the data, it is less than 20%. So if somebody has a less than 20% chance of a recurrence, I don't think I would offer her a surgery and a reconstruction. I would just tell her that you have to be careful, be under careful follow-up. And if there is anything happening again, we can immediately address. Ultimately, benign phyllodes only have a problem of local recurrence. They don't metastasize. So we are not risking somebody's life. Borderline are also, they have a very low risk of metastasis. They are again locally recurrent. So local disease we can handle. It's only the malignant variety which is of concern, because if we miss them and don't manage them properly, they have a life-threatening disease. So something which is locally recurrent can be easily monitored, can be kept under this thing, closer observation, with a complete this thing to the patient as to what is being practiced the worldwide. And that is probably what would be my take on this.
Yeah. Dr. Asha, your take on this?
Can I just ask Ruchika a question? Would any molecular markers help in a situation like this?
So this is the exact situation where your TRT promoter mutations would help. Okay. But unfortunately, right now, I don't think they are in clinical practice, not till last year. But yeah, those are the mutations which are seen in your benign phyllodes, which will not be seen in your cellular fibroadenoma.
All right.
And the best is an excision. As far as you can go, it is better to label it as one entity to avoid this confusion. But then I agree, rarely you do have cases where you can't decide between both the lesions. But maybe extensive grossing, and if you see one bad area or something, and it helps you. But yeah, molecular studies in these cases are helpful.
Dr. Charu, while we are discussing resurgery is definitely a good option for her. Considering her recurrent disease, and now that it has been reported as benign phyllodes, would you be offering her radiation now that she doesn't agree for a resurgery? Will there be a role, or would radiation compensate for her, absence of resurgery?
So the thing is, in benign phyllodes, the role of radiation, I mean, as such, had it been a borderline or a malignant, I would have been very comfortable giving it. Here, since it is a benign thing, and oblique cellular fibroadenoma, this is something, which sorts of holds me back. Because in benign pathology, I think the role of radiation, even though it is recurrent, but it was earlier also a cellular fibroadenoma, there has been no, upstaging histologically wise, if it was a cellular fibroadenoma earlier, and now either it's a borderline or a malignant phyllodes. So it has almost remained the same. So here, I mean, even with the recurrent this thing, I will not be too keen.
Okay. So in case if she had good negative margins, But considering the fact that she is a recurrent disease, a recurrent phyllodes, would you still consider her for radiation?
No.
No, not because
I
she's
would,
only...
yeah. Because she is benign stroke cellular fibroadenoma.
Yeah.
So that is the problem.
Okay. Now that she is, this is her current picture. She was actually treated 6 months ago. This is, you can see the breast deformity, and now she has come with, she's insisting that we correct her deformity. So how, is it the right time, or should we wait for furthermore, or what should be offered? Dr. Navneet.
So I think I would tell her that going in again would be desirable if she waits adequately, because if we wait for 1 to 2 years for any local recurrence, she has had one recurrence, so she will definitely be on a probability of another recurrence. So I would convince her probably that she should wait for at least 2 years, 2.5 years, maybe 3 years. Then we can do a cosmetic reconstruction. Basically, tissue is lacking in that area. So upper outer quadrant doesn't have glandular tissue, which can be managed by any therapeutic mammoplasty procedures. You can just need to kind of go in again, fill up that defect by using the local glandular tissue. She has abundant amount of breast there. Or maybe if the need be, you can get a local flap from axillary region. There's a lot of fat, which is probably you will find there. Fill up and defect, and then nipple areolar complex can be decentralized. So I think corrective surgery can be offered to her if she is keen for a better cosmesis. But I would suggest her that she waits for some more time, so that we keep the, I would not say after 2 years she will not have any probability of recurrence, but at least it will keep the probability low, because that is usually the time when they will have a recurrence. And it may result in some other quadrant, because cellular fibroadenomas are not locally recurrent, they are multicentric. So it may be another lesion developing in another area of the breast. And then we will have to make a choice according to the location of a third lesion maybe. So at times you have multiple bilateral breast fibroadenomas. I'm sure you all have come across that situation.
Yes.
So you have to keep all these possibilities. So I would wait, and maybe after 2.5 years, 3 years, reassess her, and then do the correction of the resultant residual deformity.
All right. Thank you, ma'am. So we will move on. So this is another case. A 43-year-old presented with history of excision of lump in the left breast 1 year ago, and then later on she noticed rapidly growing lumps in both the breasts. Overall duration was 4 to 5 months. And this was her mammogram with 2 large lumps on one each on either side. And corneal biopsy from both the lumps, larger lumps, were reported as fibroepithelial lesions. Possibilities again were fibroadenomas, benign phyllodes. And in on imaging, you could see that there were other lesions also. So Dr. Neeta, I would like to ask you, would you be sampling all the lesions, considering the fact that they have been, differential has been given as to whether they are benign phyllodes or fibroadenomas?
I think we'd sample what was the most radiologically or clinico-radiologically discordant lesions. I don't think we'd go and biopsy each of the small lesions. Definitely the 2 large lesions on either side, and if anything else was reported as a foray.
Okay. Dr. Rajiv?
Yeah. So on the right side, there are 2 lumps, definitely, and showing both enhancement. So I will, sorry, not enhancement, sorry, this is a mammogram. But there are 2 lesions having the same density. I will like to do biopsy of both the lesions on the right side. On the left side, the bigger lesion definitely needs biopsy. The smaller lesion, which is on the other quadrant, if that patient wants to get that removed, I would like to do a biopsy also, because that is a less than 3 centimeter tumor. In fact, what I can do a web on for that lesion if that is a fibroadenoma, so that the patient can be saved with 2 different scars. But definitely the upper lesions needs a biopsy, and if they are cellular fibroadenoma or benign phyllodes, they need a whatever standard of care as surgery.
So rightly, we did a core biopsy from these 2 larger lesions. And what surgery? Ma'am, Dr. Navneet.
Yeah, okay. So since she is symptomatic, because it is growing rapidly, would you just repeat what was the biopsy report?
It was fibroepithelial lesions.
Okay, okay.
Possibilities.
So we still have that because of the multicentricity, because of the bilaterality, probably I would think of fibroadenoma more than benign phyllodes because they do not occur in multiples in both breasts like that. So I would offer her surgery, maybe go by an inframammary incision, lift up the entire breast, get all the things which are palpable out, and then put the breast back in position. I would offer her bilateral surgery by bilateral submammary incisions, lifting the breast off the pectoral fascia and getting the as many number of tumors as out. At the same time, tell her that they may come back. So the next time when they come back, she should come when they are smaller, so they can be managed by lesser invasive means, or they may be just left alone. So if a repeat biopsy of all the specimens is again benign, probably she can be counseled that they may come back again, but redo surgeries is not the answer. For her symptomatic concern, definitely she needs surgery, and there is a possibility of a phylloid, so we must have excision with a margin. So I think going below the breast would be giving us the maximum access to the tissue and the extent of margin that we may want to excise along with that.
Okay. Dr. Neeta?
I would agree with what Dr. Navneet said. Bilateral lesions tend to be more fibroadenomas. You don't really see phyllodes presenting as multiple bilateral lesions. So you would err on the side of doing a more benign excision. The only thing, of course, is if there is any ambiguity in your mind about the core or the radiological evaluation, which is hinting towards of benign phylloids. Normally, most of us would take inframammary crease incisions, but you may want to place your incision closer to the larger tumor or the tumor which looks suspicious. So maybe even a lateral crease incision or an inframammary, whichever is more suitable for this patient.
So here she was operated by this approach. On the left side, this was the extent, and an elliptical incision was given with some excess skin was removed. And here on the right side, this was removed by a periareolar incision, and the other lesion which was closer to this areola was also removed. So on the left side, 3 lesions, and on the right side 4 lesions were removed, and 2 of these largers have been reported as benign phyllodes on final histopathology, and closest margins for both have been reported as 0.2 centimeter. Rest all others have been reported as fibroadenomas. Now what?
I would think based on the current evidence that you have from the new JGO paper, if they're definitely benign phylloids and your margins are, sorry, you said 2 millimeters.
2 millimeters, yes.
Yeah,
2
so
millimeters.
if you've got adequate margins all around it, you keep the patient on close follow-up. That's an option that you have.
Yeah.
Again, this you would need, your patient needs to be on very, very close and tight follow-up. If there's any ambiguity about, because she's come with tumors that are as large as 10 centimeters. So this is not someone who's health aware and health conscious. If you want to be able to have these discussions of conservative approaches with your patient, it needs to be a very aware patient is the first thing I would say.
So how would you do a follow-up, and what will be the imaging, and how frequently?
I think we do ultrasounds and clinical evaluations on a 6-monthly basis. We don't add in a mammo at every visit. But again, that depends on how close your patient can follow up. The first visit would be a 3-monthly follow-up also, if they are based out of the same city.
Right.
Dr. Neeta, how frequently you would like to do an ultrasound? I would like to do it around 6 months.
Yeah, so we do it at 6 months only, sir, not before that.
Dr. Asha, do you agree?
Yeah, 3 monthly follow-up and ultrasound at 6 months. Mammo probably every year. I don't think mammogram every visit. So I think ultrasound and clinical examination should suffice.
So I think we should take one last case because we are coming closer to the, if the panelists agree to take one last case, is that all right?
You're the organizer, Vaishali.
No, I'm so this is a case which Dr. Mala Mathur Sharma has shared with me. She's a 30-year-old mother of 1 child and presented with a tumor 4 months duration. Ultrasound shows a large ill-defined mass with heterogeneous ecotexture, cystic components, and there are 2 left axillary lymph nodes with cortical thickness of 5 millimeter. Core needle biopsy has been done and shows Phyllodes tumor favoring borderline. However, malignant pathology cannot be excluded. Excision is required. So what should be the further workup? As Dr. Neeta has mentioned, that probably in case if there is a suspicion that it could be malignant, she would like to do a CT scan. Would a PET scan be advised, Dr. Navneet?
I think since they have given a possibility of a malignancy, I would want a little more extensive workup. It can be CT chest or it can be a PET CT. There is an axillary node involvement also, which can be, again, which needs evaluation, right? So she would need a little more workup than just an ultrasound and the clinical assessment. It can be a CT chest, it can be PET CT. Either way, probably we will be better guided in terms of the extent of the disease. And I think I would offer her mastectomy, because in her case, this is too much. It's a giant phylloids. Skin is not worth preserving. So I may not sacrifice skin too much, which is healthy and close to the breast, to the chest wall. But she would be better off with a mastectomy, and her choice of reconstruction can be immediate or delayed. That we can discuss with the patient.
Dr. Asha, considering the fact that she probably may be upgraded to a malignant, would you agree to Dr. Navneet that immediate reconstruction can be offered to her?
Yeah, if she wants immediate reconstruction, we're going to take a wide enough margin, probably sample the nodes as well.
You would like to do the node sampling as well?
Yeah, I think we can do a node biopsy before going in, because although it's less than 5%, very rarely there can be a carcinomatous involvement of it as well. So we could sample the nodes so that we don't land up as a surprise on table. So we could sample the node as well and look at that.
So in case if you go for immediate reconstruction, and probably in case if it turns out to be malignant, and in case if she needs radiation, what will be your choice of reconstruction for her?
Any autologous flap, I think generally we could do a DF.
But she is a bit thin, and she desires children as well in future. So what will be your choice of autologous reconstruction? She hardly has any tissue, at the back.
ALT as well is something that we could do.
ALT. Dr. Neeta?
One is I am going to disagree a little with Asha. She's going to kill me for this. But I would, if you find the lymph nodes on table, I would then assess them on table with a frozen. I wouldn't necessarily choose to do that pre-op, because your patient's just going to go for surgery. As for reconstruction, I think her opposite breast is much smaller.
Yeah.
So you're going to have to match that side, fortunately, and you'll probably be able to get some tissue, whether it's if she's unmarried or wants to have children further, and you don't want to stretch out the DF and use that area, you could consider a gracilis on her. You're going to, if this is a malignant phylloids, use an implant. If you're wanting to use an implant, you're going to have to give radiation. So that's something you're going to have to consider. You're going to need a vascularized flap over that implant. So then you're discussing an LD with a cover for that, but that entire skin would go based on our principles. So that much of skin replacement with an additional volume from the LD may be difficult even to cover the implant. So I think if you can match the opposite side with a gracilis, that's something we'd consider.
Dr. Bala had probably
planned. Can I make a comment?
Yeah, yes, sir, please.
If we are planning to give radiation, instead of putting up an implant, I would like to put a tissue expander.
Yeah,
Agreed.
Right.
Because implant, sometimes radiation, the implant breaks down. So I would like to put a tissue expander, and at the end of the radiation, maybe 2 or 3 months after, and slowly we increase the volume of the saline in the expander and then put an implant. That is our practice, that if we are planning to give radiotherapy, instead of an implant, we put a tissue expander.
Yeah, I was going to come to that, because she had planned expander with a LD cover and gradually expand it. Then in case if it turns out to be malignant, radiate, and then maybe replace it with a permanent implant. That was her plan. So yes, Dr. Navneet, you wanted to say something?
Yeah, I think for a patient who's going for an immediate reconstruction, when we don't know it is going to be finally a borderline or a malignant phylloids, using autologous tissue is risking too much of a body tissue for a very small gain. So I probably would not be in favor of using autologous tissue, though there are again n number of reports when people have done immediate DF reconstruction also. So if I consider the possibility that it may turn out to be malignant and she may have a recurrence. So autologous, probably immediate, I would not recommend. Implant versus an expander, both the options are there. But I would say first of all, radiation therapy is not a routine even now in phylloids. So it is not that everybody who is reported as borderline is going to get radiation therapy. So if she has to receive radiation therapy, then obviously putting an implant is again putting it to a certain risk, and that is only of capsular contracture. Nothing beyond that happens. So she may have a implant which is feeling hard and contracted, and she can have a replacement. So this is what I saw, large number of patients coming back with capsular contracture, just having a replacement of the implant, and that is a kind of a easy option, easy surgery. So if I probably were to counsel her, I would tell her that she can have an implant. If she has to receive radiation, that implant may require a replacement because they generally tolerate poorly. Now even better implants are there. Those who have a silicone and an outer saline with lesser claimed reports of post-radiation fibrosis. So she may actually even be spared of a replacement. So I think autologous tissue reconstruction for immediate phylloids, when we don't know what the behavior is going to be, is little more risky than putting an implant, which is a simpler surgery, can be redone as and when required. And maybe she can just wait without a reconstruction for 1 or 2 years, probably, and then come back again. That can be third option.
Right. Dr. Charu, if she turns out to be a malignant phylloid and after undergoing mastectomy, what would be your criteria for taking her up for adjuvant radiation?
So the only thing is, since it is such a big phyllodes and you would do a mastectomy, so the presumption that in case if she has a next recurrence, that would be sort of, really be debilitating for her. In such a big phylloid, probably I would go ahead, and if it turns out to be a malignant, then I may offer her radiation. Looking at them, of course, the margins and the chest wall invasion, the fascia involvement, and I think all these things are to be considered.
Right. And obviously your area of radiation will not be covering nodal areas like we do it in invasive malignancies.
Yeah, of course. I mean, in phyllodes, we don't treat the SCF or the axilla. The only thing is you have got 2 axillary nodes which are there. Which just, so they will be sampled in any case. If that turns out to be, positive, then also I think just 2 nodes, we will still not radiate the axilla.
You will not. Okay. All right. This is a quick case presented with a large tumor on left side, having undergone a surgery on the right side, which was a fibroadenoma. This left-sided tumor was report. Yeah. Yes, sir.
Dr. Vaishali, I think it's already 7:54.
Okay.
So what maybe there were 2 or 3 questions which were there. So maybe we could just address those questions and leave the cases right now.
Yeah.
Would that be okay?
Yes. I think this is just a repetition. I just wanted to ask about, all right, that will be a repetition. That's all. I'll just stop share.
So one of the questions which Dr. Pragnya has asked is about nipple areola complex. So when it can be saved, when it can be sacrificed. So maybe we can have opinion from Dr. Neeta and Dr. Navneet, and let's see if there are contrasting opinions or same. Dr. Neeta.
So again, if it's a benign phylloids, it would be a different discussion. If it's a borderline or malignant phylloids, if it is the margin, if it is anywhere between 1 to 2 centimeters of that tumor, we would excise the nipple areola complex.
Okay. So what we can say is that any large tumor where the patient is going to have a mastectomy, there is no role for a nipple sparing mastectomy in phyllodes. So that is a given. Now comes to a smaller tumor, which probably, let us say, is closer to the nipple areola complex and maybe a borderline phyllodes. So how much margin would you want? Say 1 centimeter margin would be okay?
It's a minimum of 1 centimeter, but again, if it is a malignant or a borderline phylloids and it's that large, the probability of you getting a free margin under the NAC is very slim. So I think oncology would trump cosmesis for us.
So in such a case, what would be the procedure you would do? Total mastectomy or some sort of a partial mastectomy with repair?
Again, so it would depend on the size of the tumor in the breast.
Okay.
So if you have a very large tumor, as was seen in either that, I think the second case, which more or less works out to a mastectomy, when you excise that, we'd probably go ahead with a mastectomy and then discuss some sort of reconstruction of the patient's skin. If it's a smaller tumor, like was in the first case, and you can get a wide margin with a flap, maybe an LD, as was seen in that case, we'd probably do that.
Dr. Navneet, would you have any difference of opinion?
I think I am not 1 centimeter margin is not sacrosanct as per the current literature. Dr. Shankar is smiling, so maybe they also have revised the extent of margin excision that is mandated as of now. For benign tumors, I would not insist on a 1 centimeter margin if it is going to sacrifice a cosmesis badly. And especially benign tumors which grow large and come too close to skin, 1 centimeter margin is just not possible. So then we have to, if we are talking about 1 centimeter, they only can be offered mastectomy. If we are accepting a little less margin, which is as per what is the current data coming up, so in that case, a lesser margin is acceptable for benign tumors, then you can save nape areola complex just by raising flaps and either a skin sparing mastectomy or a reduction mammoplasty, whichever is feasible, can be done. Besides, the location of tumor is important. If it is not exactly behind the NSE and it is away from NSE, then anyway it can be saved without much risk to the vascularity. But if it is too much stretched under NSE, then you may not be able to save even if you have tried to kind of do a nipple areola sparing mastectomy. So 1 centimeter margin for benign tumors, I would say if it is going to sacrifice cosmesis very badly, I probably can err on the side of smaller margin. Tell the patient as to what is the current evidence, and if she has a certain risk, if she accepts, that probably can be offered to the patient.
Dr. Sankaran, would you like to add something to this debate? You're mute.
Unmute yourself, Dr. Shankar. You are not able to.
Yes.
It's a very, first of all, I have to say it's an interesting discussion because we don't see that many Cystosarcoma Phyllodes or this kind of Phyllodes tumor. For benign Phyllodes, we never excise skin or muscle unless there is a reason. And 1 centimeter, we don't adhere to 1 centimeter. But when there is a doubt between a fibroadenoma and phyllodes, we always try to get a good margin. Not necessarily 1 centimeter. We call it as a narrow wide margin because in UK, you cannot document and you do some surgery for something. You will be questioned. If you take that muscle, you will be questioned. If you don't have adequate margin, if the patient comes back with recurrence, you will be going to the court. So you have to discuss an MDT. Everybody agrees what is it. And then we go to the patient and ask the question. And people are telling about follow-up. It's very difficult to follow Phyllodes. What proof that we got that ultrasound will detect the recurrence?
Right. Yeah.
So these kind of things, it's good if the patient doesn't come. For us, patient keeps coming. So we don't have a protocol for benign Phyllodes to be followed up. We want adequate margin, and if the margin is good, we are happy. I think surgery is the most important thing. If there is any doubt, and also any between fibroadenoma and Phyllodes, if you have any doubt, always mark the specimen. Make sure that all the margins are known.
Yeah.
And we never gone in for skin margin in cancer, but this is a different scenario. As Neeta is keep on telling that it's a mesenchymal tumor. So we have to be careful with that. I think we need a good team, and we don't see these big sizes. And if it is malignant, it's better to discuss with a good super specialist because not everybody is going to see every day malignant Phyllodes.
Okay.
Better to go for a bigger center and discuss. Radiotherapy, we, as already somebody mentioned, unless it's malignant or borderline, we don't give. For breast conservation for malignant, I will be really worried. Because it has to be treated like a sarcoma. Why you want to compromise for a malignant, you want to do a conservation at all? It will come back. It will come back with vengeance if it comes back with recurrence or something. So that's our approach. But Neeta has got a very good background on number of cases because we are a small unit. We will see only limited numbers and our sarcomas gets referred to regional unit. But it's an excellent discussion, I should say. That's why I want to sit and watch what's happening in this. because it's not a very common condition for us. Excellent. Well done. I think as far as the reconstruction is concerned, only one point, if it is malignant, I wouldn't rush and do, or if I don't know whether it is malignant, I wouldn't rush and do an immediate reconstruction. Okay. Life is important before quality. We tell the patient, if it recurs, we are going breached all the things, all the planes, everything, and possibility of cure becomes less. So patient, we allow the patient to take a choice.
Thank you. There was a question from one of the delegates on email. Does anybody have experience with tamoxifen or has anybody used it in any cases? Is there any experience?
Not recommended. So we have not used it.
Okay, so I think that message goes. So Dr. Charu, I would just request you to maybe spell out when exactly would you use radiation, because we have had your opinion, but if you can clearly state out when radiation would be used in phyllodes.
So first of all, the thing is there are no prospective trials. There are only retrospective studies which have shown that, radiation adds only in preventing local recurrence and doesn't add to either DFS or OS. There was a small prospective multi-institutional study by Bath which had only around 45 patients where they gave radiation and there were no local recurrences till about 56 months. So that's the only prospective study we have. And as is the National Cancer Database, they have shown that the use of RT in phyllodes have increased from 15 to 30% in last 1 decade. And the use of RT as such in benign, I don't think so it should be there. Borderline and malignant, first of all, if it is you have got large tumors and the margins are less than 1 centimeter, then we should go ahead and offer radiation to such patients. And the second is if they are recurrent, then also we should offer radiation, again, not though in benign, and the other thing is if you feel that, if it's a malignant one, your margins are closed. And if you feel that if a patient has a recurrence and the next surgery is going to be, very deformative for the patients, again, those are the patients in malignant phyllodes where I would consider giving radiation to the patients. And of course, the kind of patients what Dr. Vaishali was showing, we do get such patients in malignant phyllodes also. Then they would again be the candidates for, the post-op RT.
Okay, thank you. Yeah. So, Dr. Vaishali, any other questions you think we need to ask or?
I think we have covered. Just let me go through what previously have been shared with us.
So are there any comments from the, sure.
Yeah, sorry, there was one question. Dr. Ruchika, is there any literature on, phylloid tumor and invasive malignancies? Because we have come across 3-4 cases where patients had synchronous phyllodes and invasive malignancy. So is there any literature available as to their synchronous possibilities?
So Dr. Vaishali, can you hear me?
Yes, yes.
Okay, yes, my video is not working, but invasive carcinomas, including in situ malignancies like DCIS, have been reported in fibroadenomas. They have been reported, there have been occasional case reports with coexisting carcinoma and malignant phyllodes.
Can I make a comment?
Yes, sir. I think we have lost Dr. Ruchika. Please go ahead, sir.
Can I make a comment?
Yes, sir. Yes,
yeah,
sir.
There are no series of fibroadenomas and phylloid having malignancy together. But when I was in Gangaram, we had a case and we have published it where there is a coexistent malignancy along with fibroadenoma. And that case has been published in the Indian Journal of Pathology, if I remember well, by the pathologist. But there are no large series because phylloid or itself is a rare not very common tumor, and there are no series. But we have published a case.
Right. I think we have covered almost all of them. In case if there are no more in the chat box, then I think we have covered.
Yeah.
Yeah.
If any of our faculty members have anything to sort of add to what has been already discussed, then I would say maybe 1 or 2 lines. Dr. Neeta, Dr. Navneet, Dr. Asha, Dr. Rajiv, if anything.
Arun, you were asking about primary reconstruction versus. Let Vani speak.
Sorry, I have interrupted you, Dr. Rajiv.
Vani, speak, please.
Oh,
you are speaking for the first time.
I have actually been quite silently being the observer, just seeing what the opinions were from various schools and various personalities here who have been talking about management of Phyllodes tumor. And I think we all forget one simple thing: the Phyllodes is, after all, a sarcoma. It's not whether it's benign, intermediate, or malignant. The most important thing is that we have to get a clear margin. The margin, of course, has been debated from 1 centimeter to keeping the skin, removing the skin, going the inframammary crease. Everything has been debated and discoursed based upon the number of patients we have seen. But I think it's very obvious that whatever you do, there is always a high risk of recurrence if you are going too close to the tumor. And higher the grade of the tumor, worse it's going to be. So I guess individually you have to assess each patient and decide whether you have a clear enough margin, whether you want to save the skin or not. But the more larger they are, your actual assessment of the tumor becomes varied, because you're not going to get a full picture by doing a biopsy or getting, there is always a varied heterogeneity, and we all agree on that. The heterogeneity decides whether or not this patient is going to come back with a recurrence. And once she's recurred, that's the end of the story. Because in Phyllodes, as Dr. Mitra has always said it, the first bite at the cherry is the only bite you ever get. The minute you have a recurrence, you are really doomed forever for a disease that can be cured completely. So I may be a little wary about trying to save and be conservative in patients who've got Phyllodes tumor. The quality of life is excellent if you can offer them a good whole breast reconstruction. Implants are an option where skin can be preserved safely, not in a 10 centimeter tumor, not in a very large tumor. So I guess we still have to look at it in that manner. I agree with Neeta. The data that we have actually audited from our institute is something that has really shown us that we have to be extremely wary about intermediate and high grade tumors. I still may not agree about a nipple undersurface shave. I read somewhere in the chat was being questioned. I don't think they have any role in a tumor which does not arise from the ducts. It comes from the stroma, and the stromal tumor has no correlation with the ductal. So what you're doing in a nipple undersurface is actually shave of the ducts. So I guess we really need to take all this into consideration before we say that one can offer, skin-saving mastectomies, or agree that cosmesis is very important, but cosmesis cannot be at the cost of oncological clearance.
I think I agree. Dr. Vani is wonderful comments. And I would say, though, I don't see too many fibroadenomas being primarily in oncology, but generally I don't like to do a simple enucleation. I would always remove with maybe 4 or 5 millimeters of margin. Maybe being an oncologist has sort of made me a little more aggressive. So getting a sort of positive margin at a surprise diagnosis is generally not a possibility, even though it may be close. So I think though some of the controversies have not been resolved, but we have heard from the experts, and we'll have to make decisions. But what is critical is that a good radiology and pathology support is very important. Try to take adequate samples. If there is a doubt, maybe go for a rebiopsy, maybe take an opinion from another pathologist who focuses more on breast pathology. Discuss the possibilities with the patient, the possibility of upstaging, the need for resurgery, and definitely be convinced about the need for resurgery. Right? Then only you can convince the patient. These are the messages. So with that, I would like to say thanks a lot to all the faculty, Dr. Neeta, Dr. Ruchika, Dr. Rajiv, Dr. Navneet, Dr. Asha, and Dr. Charu who's left. Dr. Vani, thank you. Dr. Sankaran, thanks. And everybody else who was there. We have had many colleagues from Bangladesh joining in from last few events. And thank you all of you for joining. And hope to see you again in another 2 weeks with the next event. Thank you.
Yeah.
Thank you. Thank you.
Thank you, sir.
Uh,
Thank you.